Hi, my name is Robin Berkey, and I'm an assistant professor of neurology and a neuro-oncologist at the Malnati Brain Tumor Institute of Northwestern University.
Okay, Dr. Berkey, DVT, deep venous thrombosis, it's a common clinical problem. How often do you see it with brain tumor patients?
In the brain tumor population, we see venous thromboembolism and DVT quite commonly. This is something that our patients are at high risk for based on their tumors themselves, but also factors associated with having brain tumors. The oncologic medications we use, as well as immobility and weakness.
How often do you see this? How often is it a clinical problem for you?
At least once a week, we'll see a patient with a new venous thromboembolism. In some cases, these are patients who have been recently treated, and in other cases, it could be a patient who's many months after their surgery or after their treatment. In other words, they're off any active therapies.
You mentioned patients on treatment. If they get a DVT, what happens in the middle of their treatment course?
This can be, I sometimes call it a bump in the road for our patients if it's caught early, but if not, this can potentially be a life-threatening or even fatal risk that our patients have. What happens when a patient gets a new blood clot is if they're symptomatic, oftentimes we have to admit them to the hospital or go through the emergency room to start anticoagulation. And because of the risk of bleeding in the brain, we take the starting of anticoagulation very seriously, and we want to do it in a careful way to try to mitigate that risk. Even if the patient has minimal symptoms from the clot itself, any time we're starting a new blood thinner or anticoagulation therapy, we want to do it in a safe way. And I would add, this is also true for patients with brain metastases as well, that we're sometimes worried about their intracranial bleeding risk. Typically in our patients, we'll use either a low molecular weight heparin drug, or if we want to extrapolate from other cancer types, one of the new oral anticoagulation drugs.
So it sounds like there might be risks associated with these anticoagulation drugs. How often do you see a complication from starting a patient on anticoagulation?
The risks of starting anticoagulation are significant in our patient population. And the concern for me as a neuro-oncologist is, are those risks going to outweigh the potential risk of the pulmonary embolism or venous thromboembolism? Some of the risks that we see include increased risk of bleeding, and that can be major bleeding, such as intracranial bleeding or gastrointestinal bleeding, but also less clinically relevant bleeding that still is important for patients and can impair their overall treatment plan. How I determine if a patient is at risk for venous thromboembolism or DVT is often using risk models that are not specific for our brain tumor population and that are adapted from other cancer patients, but also we use soft factors in our brain tumor patients. Age, weakness or immobility, medications that the patient is taking, often we consider those to be higher risk for developing blood clots. But many of these factors are not things that I can put a specific number for their risk or give them a specific risk of having that clot in the next year, for example.
I'm not trying to put you or your colleagues on the spot, but do you think there's consistency amongst your colleagues with regards to when you start anticoagulation, among your partners, etc.?
As a neuro-oncologist, there's a lot of practice variability in terms of when we start anticoagulation. The patients who might be at highest risk, who are completely immobile, and who we feel that their bleeding risk might not outweigh the risk of starting anticoagulation, we routinely treat. Other patients who don't fall into that category, who might have a few potential risk factors, but we're not often sure exactly what their risk for a venous thromboembolism might be, we typically don't treat with prophylactic anticoagulation. We might wait until if they develop a blood clot to treat them. But even in patients who have an active blood clot, the choice and duration of using anticoagulation is quite variable. Some prefer the older drugs in the heparin class, like low molecular weight heparin, and others are more comfortable with some of the newer oral non-vitamin K antagonist drugs.
I'm surprised there's not some kind of guidance around this. Is there not?
There is guidance for oncology patients in general, published by some of our national societies, but a lot of those guidelines specifically include patients with primary brain tumors and often include patients with brain metastases as well. If we're looking at large published clinical trials, large published data sets, we often have to use our best judgment to see if our patients might fit those same factors. One area where this becomes problematic for us is estimating a patient's risk of having a blood clot in the absence of those guidelines. And we know that our brain tumor patients are at a high risk of developing blood clots, but we have a difficult time estimating that risk and being able to predict which patients are specifically going to develop a blood clot.
In a manuscript that's published in Blood, there is an app that has been provided as part of that publication, which gives a relative risk assessment for a patient based on a variety of characteristics. I'm curious, where in your clinical opinion would you want to start anticoagulation, having reviewed that manuscript and having looked at that app? Is if you had a patient that had 10% risk of a DVT, 20%, 30%, where would you actually, in your clinical judgment, want to trigger the initiation of anticoagulation?
Using an online app or a phone app, an online calculator tool, has become very common for neuro-oncologists and in medicine in general. And we're very comfortable looking at such calculators both for blood clotting risk, for patient survival. There's a number of survival nomograms that have been published for our brain tumor patients, and we routinely look at these. For me, as a neuro-oncologist, patients who are at a high risk, and to me that would be over 10% in the next 6 to 12 months, we should consider talking to them about prophylactic anticoagulation. And oftentimes the patients are inclined to start a preventative treatment such as that, given their concerns about blood clots.
In your neuro-oncology clinical expertise, is this a tool that needs some additional kind of clinical trial, assessment, some kind of study to fully validate the potential of utilizing this app in this patient cohort?
If I want to use this prediction tool as a neuro-oncologist, I'm trying to estimate for myself if it reflects a similar patient population. And even though there was not a prospective validation of this app, it was validated in independent groups of patients from similar institutions who had similar characteristics to patients that we see here at Northwestern. I'm always going to want the highest quality data to be able to make a recommendation, but from a practical perspective, we often treat patients based on prediction tools that show that they can be effective at estimating risk in groups of patients without needing a prospective validation study.
What were the key or most interesting findings from that paper in Blood when you read it?
The most interesting findings for me as a neuro-oncologist included that medications we use, for example bevacizumab, did not actually lead to increased risk of venous thromboembolism. This has been shown in some retrospective series before, but this was a large data set that really looked at several factors. Another fascinating piece of this paper reflected the role of IDH mutations and MGMT promoter methylation status on developing venous thromboembolism. So we know that patients who are at higher risk for venous thromboembolism are likely, based on this, to be those that have IDH non-mutated or wild-type glioblastomas, as well as who lack MGMT promoter methylation. So there's a patient I'm seeing today in clinic who I'm curious, and I want to be able to determine her risk of having a venous thromboembolism. So the app is an easy-to-use online tool that's looking at 10 fairly straightforward factors about my patient. So the first one I need to input is her age at diagnosis. Her BMI that I can input as well is 27, and her most recent white blood cell count. Then from her original pathology report, there's some factors about her tumor that I know that I can input as well. Whether or not she has an IDH mutation, she does not. Whether or not her tumor has methylated MGMT promoter, it does not. And also the original grade of her tumor. Hers was a grade 4 glioblastoma. And then there's a few factors about this patient's past medical history that I need to input as well. Whether or not she has a history of hypertension, history of hypothyroidism, any asthma history, or a history of having a venous thromboembolism, and she had a DVT in the past. When I put all of those in at the top of the page, it gives me an estimate of her risk of having a venous thromboembolism. And in this patient's case, she's at extremely high risk, over 35% in the next month and 85% within the next year of developing a venous thromboembolism. So for my patient, I can see that she has a very high risk, 39% in the next 1 month and 85% risk of developing a venous thromboembolism in the next 12 months.